Hello, my name is Andrew Lane. I'm from the Dana-Farber Cancer Institute and Harvard Medical School. This presentation is on novel targeted therapies and combination strategies in BPDCN. This slide summarizes the therapeutic modalities available to us for BPDCN. Prior to 2018, we had simply conventional chemotherapy and stem cell transplantation. But in the modern era, we have a newly approved drug and several others in development. These generally fall into two classes: the agents that target CD123, or the IL-3 receptor. This includes Tagraxofusp, or SL401, the diphtheria toxin interleukin-3 conjugate that was approved in December 2018. There are also several other agents that target CD123 that are in clinical trials. These include CD123 antibody drug conjugates, bispecific T-cell engagers targeting CD123, or CD123 CAR T-cells. I'm not going to speak about those. Those will be covered in another lecture. But I will speak about the treatments in the blue box, which are novel treatments and combination therapies, including with Venetoclax, Tagraxofusp combinations, and other targeted therapies with potential in BPDCN. We and others performed work that discovered that BPDCN tumor cells express high levels of the anti-apoptotic protein BCL2. On the left are pathology slides from bone marrow and skin BPDCN tumors, showing the morphology by H&E and CD123 and TCL1 immunohistochemistry staining that marks the BPDCN cells. And you can see that in every case, the BCL2 protein is expressed at a high level. BCL2 is a protein that protects cells from undergoing cell death or apoptosis. But having high levels of BCL2 does not necessarily mean that a cell will be dependent on that BCL2 for survival and therefore be a good target for drugs that inhibit BCL2. So on the right side of the slide is an experiment we performed, published in 2017, called BH3 profiling. This is a laboratory assay that determines how dependent a given cell is on certain proteins to protect it from dying. And when cells are stimulated with external stimuli, such as the drug Venetoclax that inhibits BCL2, one can measure the increased likelihood that that cell will undergo cell death. What we found was that BPDCN cells were quite dependent on BCL2 and very sensitive to the inhibitor Venetoclax. On the left, in black and gray, are primary patient samples from BPDCN tumors and patient-derived xenografts. And compared to AML leukemia cells, or normal bone marrow, NBM, the BPDCNs are all markedly more primed to undergo apoptosis or cell death after treatment with the BCL2 inhibitor Venetoclax. This led us to perform several experiments in the laboratory and to also treat 2 patients with multiply relapsed BPDCN in a pilot study using single-agent Venetoclax therapy. Here are pictures from those 2 patients, showing on the left a patient with extensive skin and mucocutaneous involvement that had a significant disease response to 4 weeks of single-agent Venetoclax, and a patient on the right who had significant lymph node involvement who also had a significant response as seen on this PET scan. This led to an ongoing phase 1 trial of Venetoclax in BPDCN that is currently open and enrolling at several sites. Venetoclax is now approved for use in several other blood cancers and has been tested in combination with other therapies such as intensive or non-intensive chemotherapies. In fact, in acute myeloid leukemia, or AML, a disease that we think is similar to BPDCN, Venetoclax is quite active when combined with hypomethylating agents or low-dose cytarabine. And because of that, there have been several case reports of patients with BPDCN receiving Venetoclax combinations. DiNardo et al. In 2018 reported a large series of patients with myeloid malignancies who received Venetoclax plus a hypomethylating agent. 2 of those patients had multiply relapsed BPDCN, and they reported that both of them had a, quote, major response that was clinically relevant, although it did not meet formal criteria for response. A case report in the New England Journal from from Aga et al. In 2018 reported a single patient with BPDCN who received bortezomib and simvastatin, quickly followed by venetoclax for several months, who had a 9-month complete remission at the time of reporting. And finally, we reported the combination of venetoclax with a high-intensity acute leukemia regimen called hyper-CVAD. These were 3 patients who were younger and therefore able to tolerate intensive chemotherapy. One of them was in their first line of treatment, and 2 of them had relapsed refractory BPDCN. All 3 achieved a complete remission, and one of the relapsed refractory patients went on to an allogeneic stem cell transplant. So while these are small case series, it suggests that venetoclax in combination with chemotherapy, like is active in other blood cancers, might also be active in BPDCN. Now that we have Tagraxofusp approved as a single agent in BPDCN, it makes logical sense to consider whether or not combinations with Tagraxofusp would be more active in BPDCN. We don't have any clinical data yet for combinations with Tagraxofusp in BPDCN, but our group reported on preclinical data at the ASH meeting in 2017. We found that AML and BPDCN cells that became resistant to Tagraxofusp in the laboratory did not lose the CD123 target, but rather resistance was related to loss of genes in the diphthomide pathway, which is necessary for diphtheria toxin to kill cells. This resistance was related to DNA methylation of these genes and was reversible by the hypomethylating agent azacitidine. This led to a now ongoing open phase 1 trial of Tagraxofusp plus azacitidine in patients with AML and MDS, and testing of this regimen in BPDCN is planned. Other possibilities for future consideration are combining Tagraxofusp with intensive chemotherapy in younger patients who can tolerate, or in combination with venetoclax with or without azacitidine or hypomethylating agents based on what we discussed in the last slide. These trials are not yet open, but they are in planning stages. Finally, we can consider whether there are other novel therapies that have at least preclinical or case report data that will require additional clinical testing, but have some promise in BPDCN. I mentioned hypomethylating agents already, but there are several preclinical reports suggesting that these may be particularly active in BPDCN cells. Bortezomib is a proteasome inhibitor that is approved for therapy in other blood cancers, and there are preclinical data suggesting that BPDCN is particularly dependent on the NF-kappa B signaling pathway, and that treatment with bortezomib downregulates the REL-A subunit of NF-kappa B, leading to death of BPDCN cells. There's also the case report I mentioned on the previous slide with the combination of bortezomib, venetoclax, and a statin that was also active in one patient with BPDCN. Bromodomain inhibitors are in clinical testing in a number of cancers, and there are preclinical data suggesting that BPDCN cells may be particularly sensitive to treatment with a bromodomain inhibitor. Sarabelli in Cancer Cell described the enhancer landscape of BPDCN and plasmacytoid dendritic cells that is particularly dependent on bromodomain proteins and can be inhibited with bromodomain inhibitors. And Imaldi in Blood in 2016 reported that the gene NR3C1, which is a glucocorticoid receptor, is also controlled by bromodomain inhibition and is important in BPDCN biology. Finally, there are a number of possibilities for treatment of BPDCN based on the disease genetics. There are a number of RNA splicing factors that are mutated in patients with BPDCN, as had been reported in the literature. And there are splicing modulator drugs being tested in other blood cancers that harbor these same RNA splicing factor mutations. And finally, there are IDH inhibitors that have been approved for patients with AML that harbor IDH1 and IDH2 mutations. And there are a number of reports that BPDCN cells can have IDH2 somatic mutations, suggesting that they might also respond to the same IDH inhibitors. So to summarize, venetoclax, the BCL2 antagonist, is active in BPDCN. Venetoclax combinations are also active in small case series and warrant more clinical testing. Tagraxofusp plus AZACITIDINE is currently being tested in AML and MDS patients and is a possibility for testing in BPDCN. And other novel agents with preclinical data are possible in future clinical testing for BPDCN as well. Thank you for your attention.